The following podcast is part of a certified educational activity titled Taking Stock of Potential Advances in the Early Diagnosis of Alzheimer's Disease. What are the implications for treatment? Access the entire activity and complete the post-test at www.peerview.com/JJS. Downloadable slides and practice aids are also available. Welcome to this educational activity, where Dr. Marwan Sabah from the Cleveland Clinic Lou Ruvo Center for Brain Health discusses the role of biomarkers in the early identification of Alzheimer's disease and the latest data on emerging therapeutic interventions for its treatment.
Today I'm going to talk about the early identification and treatment of Alzheimer's disease. As you know, Alzheimer's is the most frequent cause of dementia. It is a chronic neurodegenerative disease featuring progressive memory loss, cognitive performance deficits, and loss of functional abilities. I don't need to tell you, the numbers are real. It is the sixth leading cause of death. 5.7 million Americans have it. That keeps growing every year by roughly 200,000 people. We'll have 14 million Americans having it by the year 2050. The cost of total care will increase to $1.1 trillion. In fact, some estimates say this is the disease that bankrupts Medicare just by itself. This is an expensive disease. It is a huge burden on society. The economic and social burdens of Alzheimer's involve caregiving, involve placement, involve hospitalization, involve multiple assessments, etc. However, there are major hurdles to making an early diagnosis. Physicians are reluctant to make a diagnosis. The average diagnosis is delayed by about 2 to 3 years. In this respect, early and accurate diagnosis could save trillions of dollars in medical care costs if we could diagnose it earlier, intervene earlier, and change the total trajectory and outcome. The Alzheimer's disease is a disease that goes from preclinical stage through mild cognitive impairment through dementia. So people ask me, what's the difference between Alzheimer's and dementia? And I say Alzheimer's is a kind of dementia, but in fact, it is the entirety of the disease from the preclinical change up to 20 years before the first state of symptoms, all the way to the end of the disease. We want to establish a diagnosis early, and there are not a lot of tests being deployed in the preclinical stage. So there are a lot of competing hypotheses when it comes to Alzheimer's disease pathophysiology. There's the amyloid hypothesis, there's the tau hypothesis, there's the cholinergic hypothesis. And people say, well, it's one or the other, and that's kind of reductionist. The fact is that they're all probably important. The amyloid hypothesis says that amyloid is the key core feature that drives Alzheimer's disease. It is an early event that leads to toxic oligomers, toxic subforms, which damage the cellular milieu, which can probably cause tangle formation. The cholinergic hypothesis was the earliest of the three that were identified, and that is the loss of the neurotransmitter acetylcholine, which we know is the neurochemical substrate for the memory loss. That's what is the cornerstone of current treatment. We know that it's an early event. It occurs right in the transition from mild cognitive impairment to early dementia, and that there are disruptions of the neuronal networks that are related to the cholinergic system. The tau hypothesis says that hyperphosphorylated tau seeds from neuron to neuron once there's neurodegenerative breakdown of the neurons. And that hyperphosphorylated tau no longer binds to the microtubules, and in so doing, it causes abnormalities of microtubules, which leads to the neurofibrillary tangles. People know Alzheimer's as the dementia when they lose their functional ability, but in fact, the entire disease occurs decades potentially before the onset of symptoms. In the preclinical stage, we know that they're accumulating to pathology, but are not having function or symptom changes. In the mild cognitive impairment stage, this is also known as prodromal Alzheimer's disease, and we see patients having minimal cognitive symptoms without functional impairment. And then when they progress into the mild Alzheimer dementia stage, it's when they start to lose instrumental activities of daily living. Moderate is the activities of daily living, and then severe is when they lose mobility, speech, etc. Welcome back. Now I want to tell you a story about a patient. His name is Michael. Michael's a 68-year-old Caucasian man, married, who retired about a year ago as an accountant, which he was practicing for more than 40 years. He exercises regularly 2 to 3 times a week, consumes 4 to 5 drinks per week, usually with dinner, non-smoker. He enjoys playing golf once or twice a week. Recently, during a visit to his primary care physician for his annual physical, his wife explains that Michael is having a little bit more difficulty with his memory, probably for about 6 months. She notes that he's a little bit more irritable, more short-tempered, having a little bit more trouble sleeping, and a little bit of insomnia and some forgetfulness in the past few months. On one occasion, he forgot how to drive home or lost his sense of direction from the nearby supermarket. His medical history is not that impressive. He has a little bit of hypercholesterolemia, a little bit of hypertension, a little bit of enlarged prostate, no history of stroke, head trauma. He had a little bit of a concussion when he was skiing in his 30s, mild concussion, no gait abnormalities, no balance problems, no family history of Alzheimer's or any dementia. His physical exam shows normal blood pressure, 119/81. The primary care physician does a screening lab test. Cholesterol is normal at 180 milligrams per deciliter. TSH and B12 are normal. The primary care physician does a screen for depression, and the PHQ-2 is negative for depression. He does an Epworth sleepiness scale, which is consistent with some sleeping issues. So after listening to Michael and his wife, the primary care physician was a bit concerned about Michael's cognitive function, and appropriately so. The results of his medical history were provided, which showed no information that could inform why he's having a memory issue. The primary care physician does an informant-based questionnaire and some cognitive screening measures, including the mini-mental state exam and the Montreal Cognitive Assessment. In the mini-mental, of course, everybody knows it's 30 points, testing orientation, memory, calculation, and language function. My rule of thumb is a 27 or above, I think, is normal. Mild cognitive impairment might be 24 to 27. Some people go down to 21, 22. Mild dementia might go from 20 to 25, 26. Moderate dementia from 10 to 20, and severe dementia below 10. MoCA, as a rule of thumb, patients do worse. You're testing orientation, calculation, memory, attention, concentration, executive language, and visual constructional abilities. I consider MoCA of above 26 to be normal. In this case of Michael, his mini-mental was 27. He recalled only 1 out of 3 after a brief delay, and he could not copy the complex figure. The MoCA was worse, as I predicted it would be, and he lost all 5 items on his recall task. He could not copy the cube. He had trouble drawing the clock. So the reason that's important is that you might say that the mini-mental was normal, because the mini-mental of 27 might be argued as normal, therefore there's nothing wrong. But I showed you already, or I said to you before, that the MoCA is often worse. And the 23 of MoCA may want you to consider exploring it further, may flag the possibility of mild cognitive impairment, and you see that there's memory, visual, spatial, and executive function. People ask me, what more should a primary care physician do? I say to you, that's good enough. The fact that you recognize there's a worry, you screen for depression, you screen for other possibilities, you looked at their labs, that's the appropriate time, especially if you're worried about a real cognitive impairment, to refer on. And the primary care physician did just that. They referred it to neurology. The neurologist did an MRI and ordered CSF testing. I will say to you, I'm partial to CSF testing. We're going to talk about that for a few minutes, but the reason I'm partial to CSF testing is this guy's a young man. He's only 68 years old. We need to explore this in greater detail. So the primary care physician refers to the neurologist. 3 months later, Michael and his wife go to see the neurologist. Upon arrival, the neurologist re-administers the mini-mental and the MoCA and the Alzheimer's disease caregiver questionnaire, which is administered to the informant. The neurologist gets a MoCA of 22 and a mini-mental of 25. On this mini-mental, his 2 out of 3 is lost on the recall. He has difficulty spelling world. And yes, there's all this debate about should you do serial 7s or world, but suffice it to say that he says DLROW or ORW as opposed to ROW. He has trouble drawing the complex figure. On the MoCA, he has trouble again with the cube, the clock, and the 5 out of 5 on the recall task. The informant-based questionnaire, AD caregiver questionnaire, Michael's wife endorsed forgetting conversations, repeating questions, and deficits with executive function. The neurologist orders the MRI and performs a lumbar puncture. Historically, we use MRI as a diagnosis of exclusion. And what I mean by that is we're trying to exclude other pathologies. That's based on the previous criteria for Alzheimer's dementia. So the MRI would be screening for mass, pH, cerebrovascular disease. But nowadays we're starting to do a lot more of this volumetric testing, and this is this NeuroQuant technology which shows that the hippocampal volumetry can show sensitivity. And so if the hippocampal volume is low, that is below the 5th percentile, that is quite sensitive for a neurodegenerative process. I will tell you that as a practitioner, I like NeuroQuant, except that it has good sensitivity and lousy specificity. And what do I mean by that? If the volumetric change on the MRI shows that there's very small volumes in the hippocampus, that is very sensitive for a potential for neurodegenerative disease. However, if the volumes are above the 5th percentile, say in the 20th percentile, it doesn't really inform you that much. So in addition to ordering the MRI, I would do a lumbar puncture, and we do them in my office at the Cleveland Clinic. And when we send the CSF analysis, we're sending it for 3 proteins, amyloid, total tau, and phosphorylated tau. If it is prodromal Alzheimer's dementia or full Alzheimer's dementia, we would expect to see amyloid going down, total tau going up, phosphorylated tau going up, and the amyloid tau index, ATI, would be below 1.0. In this case of Michael, you see that the ATI is very low, 0.27. The amyloid is low, below 500, and the total tau is very high at 1,000 picograms per ml, and phosphorylated tau is elevated at 95. We know that low tau suggests that the amyloid is being sequestered in the plaques. The total tau going up suggests that there's brain injury. It is not specific or sensitive to Alzheimer's. It is just seen as a marker of brain injury and can be seen in a variety of diseases. But when phosphorylated tau goes up, that is a clear marker of neurodegeneration and therefore can be embedded in the test and be very informative. So the amyloid tau index being so low with low amyloid, high tau indicates that the patient really does have an Alzheimer's disease process. So then the question becomes, what is his diagnosis? Is it probable Alzheimer's dementia, possible Alzheimer's dementia, mild cognitive impairment due to Alzheimer's dementia, dementia unlikely due to Alzheimer's disease? My particular approach is to identify the state and then identify the etiology. So I say this to you because if you're going to say mild cognitive impairment, that's the state. What is the etiology? Is it Alzheimer's disease, Parkinson's, Lewy body, frontotemporal, etc.? Same thing you should say for dementia. Dementia due to Alzheimer's, Parkinson's, Lewy body, frontotemporal dementia, etc. So always try to identify the state and then identify the etiology. In the case of dementia, you need to know that dementia by definition is a progressive cognitive change with an associated functional impairment. The domains you want to look for are memory, executive dysfunction. They may or may not have agnosia. They may or may not have apraxia. They can have a language deficit. They can have abnormal comportment, behavior, and personality change. They usually have change in functional ability, so change in their performance function from a previous level of abilities. And you can document this in the HPI and objectively with bedside testing. And sometimes you may or may not do neuropsych testing depending on what you want to do. But the key element here is that you have impairment in functional and daily abilities, and that there are no major neuropsychiatric disorders or delirium. While you're examining your patients, you should be doing a very careful history. You should be doing a very careful exam. Looking at, for example, eye movements. Is there problems with vertical gaze? Looking at their motor gait. Is there pyramidal or extrapyramidal or gait dysfunction? Is there apraxia? Is there dysautonomia? Is there sleep disturbance? Is there dream enactment behavior? If you see dream enactment behavior or Parkinsonism, you might think about other conditions like Lewy body or PDD. And if you see visual fixation or vertical gaze impairment, you might think about PSP dementia. My point is that not all dementia is Alzheimer's, but all Alzheimer's in its progressive stage is dementia. So the core criteria for Alzheimer's dementia, by definition, according to McCann, is that first you have dementia. You have the functional impairment with the cognitive impairment. The key from an Alzheimer's dementia core is that you should have two features, mostly amnestic. You may have some language, visual, spatial, or executive, that it is reported months to years, and it is progressive in nature, and there is at least an amnestic component. The McCann criteria of probable Alzheimer's dementia considers biomarker evidence supportive and advisory but not essential. But the Alzheimer's dementia core criteria should exclude cerebrovascular disease, the core features of Lewy body dementia, abnormal behavioral variant frontotemporal dementia, so abnormal comportment and behavior, abnormal language, particularly progressive aphasias, what you see in language variant primary progressive aphasia, or predominant language features, and then would exclude other things like neurological conditions that could affect cognition as well. Possible Alzheimer's dementia, and we see that we're often confounded by the fact that there seems to be clinical evidence or suspicion for Alzheimer's dementia, but there are confounders. A gait abnormality, a history of epilepsy, or a history of stroke, that you're saying, well, this is more than simply a stroke, it could be Alzheimer's, so that's why we still include possible Alzheimer's dementia. Mild cognitive impairment, again, is a descriptive state. It is not normal for age, not severe enough to be dementia. They have a cognitive impairment, and it appears to be progressive in nature, but it's not severe enough to be functionally impaired. They have, for the most part, preservation of independence. In this case, I often like to order neuropsychological testing because I am looking for whether it's amnestic or non-amnestic. If it's non-amnestic, I'm looking for a lot of different things. If it's amnestic, I'm starting to think about Alzheimer's as the pathology. But what I'm trying to say is that we look at neuropsych testing to look at where they are on their age and education adjusted means for things like memory, language, visual, spatial, etc. We know in most cases that mild cognitive impairment is the prodrome of the dementia. And that's why some people refer to it as prodromal Alzheimer's disease. And that is the clinical criteria. So again, I define the state as mild cognitive impairment, and then I define the disease as Alzheimer's disease. So mild cognitive impairment due to Alzheimer's disease. I will say to you this. People ask me what kind of tests should I order for mild cognitive impairment? And that's a good question. I've actually asked the definitive authorities in this area about what are the best tests. I myself will start with neuropsych testing, particularly in a guy like Michael, who's a young man. I would order CSF testing. I don't typically order FDG PET in mild cognitive impairment because the sensitivity gets poor as you get high on the mini-mental. I will order a volumetric MRI looking at the hippocampal volumetry. And so in the CSF testing, I'm looking at A-beta 42, phosphorylated tau, and total tau. Should I order amyloid PET? I would love to. As you know, that Medicare doesn't pay for it. We had it done through the IDEAS program last year. As you know, just reported, amyloid PET was shown to be highly informative to physicians in practice. After 18,000 scan, presence of amyloid PET altered the clinical diagnosis or management up to 60% of the time, and therefore changed the way we approach the patient. However, it is still not reimbursed, and it is quite expensive. The reason I'm telling you all these things is that people ask me what test do we order along the path. And that really depends on where you are. In the mild dementia, you might order FDG PET, you might order CSF testing, you might order MRI. In the MCI, you might order MRI and CSF testing and neuropsych testing. In the more advanced dementia, you might not order neuropsych testing because they're too impaired. Or you might think that if they're very old, they may not need lumbar puncture. So again, a lot of this, it depends on where they are. We are not seeing patients in the preclinical state except in clinical trials. And I think that there is clearly a push toward adding patients in preclinical state to screen them, but this has not become part of the clinical practice yet. In clinical practice, when we talk about using imaging, we would use MRI, broadly, structural imaging. I like FDG PET in the symptomatic dementia stage. I do not use it in mild cognitive impairment. So roughly speaking, if I'm going to get FDG PET, it would be below a mini-mental of 25 or 24. I love amyloid PET if I can get it paid for, and I use it in amnestic mild cognitive impairment and mild and moderate Alzheimer's dementia, but I would not order it unless I could get it paid for, and I might use CSF as an alternative. That's a sticking point right now in the field. I don't think we've settled on that particular issue. And I will say to you this, and I said this already, if their hippocampal volume is not low, it does not exclude Alzheimer's as a pathology or process. It just means that they haven't gotten severe enough in their atrophy. So here is a very important point I want to make. Physicians need to start thinking in a transformative manner. Stop thinking about Alzheimer's dementia as a diagnosis of exclusion. That is to say that we do a B12 TSH MRI, there's nothing wrong with the B12 TSH or MRI. De facto, we need to move the field toward a diagnosis of inclusion. And I will say to you, the technologies exist, they're approved, they're available, but not commonly used in U.S. neurological practice. It is imperative that we start to use, think about biomarkers such as a lumbar puncture. This is the newest data suggesting that if your amyloid is low and your tau is high, the sensitivity is 95% and the specificity is 83%. So why is that imperative? The traditional approach, a diagnosis of exclusion, MRI, B12 TSH, to exclude other pathologies, has a sensitivity below or around 70%. So I'm telling you that if you go from a diagnosis of exclusion to a diagnosis of inclusion, you're going from a sensitivity of a roughly 70% to a sensitivity of 95%. And you can predict progression. Well, lumbar punctures are widely available. The problems are they're not used commonly in clinical practice, at least for Alzheimer's. Of course, if you have meningitis or MS, you might get a lumbar puncture, but you don't get it for Alzheimer's. And there's this arbitrary distinction around this. The CSF testing is not widely reimbursed by U.S. commercial payers. There's a lot of questions about lumbar puncture complications and headache rates. We used the Sprott needle and found that the headache rate went from about 20% down to 1%. And the assays might be variable. The kits and the tubes can cause problems with the amyloid detection, and there's a lot of changes going on. This is an area that's under intense research. There are multiple companies in the United States and Europe that are trying to develop better, more efficient, and cheaper assays for CSF testing of Alzheimer's. If they have dementia, but you're not thinking about Alzheimer's, you need to think about other things: Lewy body, Parkinson's, frontotemporal, HIV, Huntington's. In that case, I might order CSF testing, but I know that probably the amyloid tau ratios are different. And so if I'm suspecting something strongly besides Alzheimer's dementia, I may not order biomarker testing for Alzheimer's. So here we circle back to Michael. And the question is what is the diagnosis in Michael's case? And the answer is you can make an argument for probable Alzheimer's dementia or mild cognitive impairment due to Alzheimer's disease. We clearly have identified there's a cognitive impairment. We're debating whether there's a subtle functional impairment, and that's why there's a debate between the dementia and the mild cognitive impairment. The CSF biomarker data clearly suggests that the Alzheimer's is the main cause. So is the hippocampal volumetric changes on the MRI. You have seen that there are no other etiologies to explain. No stroke, no mass, no pathology on MRI, no NPH, no B12 or TSH abnormalities, no depression, etc. So we know we've excluded other possibilities, and we've included the possibility of Alzheimer's dementia or Alzheimer's disease because of the CSF tau. Again, debating whether we're in the full dementia state or the mild cognitive impairment due to Alzheimer's disease. So the diagnosis is discussed with Michael and his wife. There are a lot of communication points that we want to discuss related to risk of progression, prognosis. When we return, we will continue Michael's story and highlight some of the novel approaches being investigated for the treatment of Alzheimer's in its early stages. Welcome back. Let's return to Michael's story. Now remember, Michael's 68 years old, so this is going to be a hard conversation. And after a lengthy and emotional conversation, Michael's neurologist explained to him and his wife the diagnosis. They discuss the available treatment options, they talk about goals of management and what to expect. Before I get into some details, I want to say to you that the second thing I want you to get out of today's talk, besides the fact that we can diagnose Alzheimer's disease from a diagnosis of exclusion to a diagnosis of inclusion, is that Alzheimer's disease, Alzheimer's dementia, is treatable. The feudalism, the nihilism that is pervasive in the field is a thing of the past, that we actually have a condition that warrants investigation and warrants treatment. We can acknowledge that the treatments that we have some limitations, but that does not mean we shouldn't try. The classes that we have in front of us are the cholinesterase inhibitors, which are donepezil, galantamine, and rivastigmine. Donepezil and rivastigmine approved for mild, moderate, or to severe. Galantamine, mild to moderate. Memantine, which is approved for moderate to severe, but not mild. Or the NMDA antagonist, which is for moderate. Combination is approved for moderate to severe Alzheimer's. NMDA antagonists can be used in combination with cholinesterase inhibitors. But we also have to acknowledge what our current treatments do and what they don't do. And we have to acknowledge that they are limited in what they can achieve. They are really symptomatic treatments. They are intended to improve the symptoms and alleviate the symptoms. They do not, for the most part, alter the progression. Maybe a little bit, but most people would say not a lot. They have some benefit in some people for some period of time. They do not target the pathology specifically. They do not target the amyloid and the tau, and therefore cannot be considered to be true disease-modifying therapies. And we need to look toward the clinical trials as ways of altering or halting or arresting the progression. Taking into account the challenges faced and the achievement up to date, early recognition, intervention, and prevention will be crucial turning points for Alzheimer's research. Back to Michael. The neurologist has a conversation with Michael. They talk about treatment options. Michael's wife asks if there's anything to slow it down. I get that question in my clinic every day. So, doc, what else can I do to stop my progression? The neurologist should be informed about what are available, not just the treatments that are approved, that is to say the drugs we've already discussed, but what can be done more than that. Hopefully the neurologist will say there are a number of clinical trials going on, that they're being investigated, and there should be a discussion about that as an added value to the clinical practice research. So let's speak about clinical research for a few minutes. Let's speak about what are available and what are the approaches and why. The dominant approach in the last decade or so has been really about amyloid. The idea that we can remove amyloid or reduce its production, and in so doing we can alter the progression. And so let's distill this into two general categories: production and clearance. And there have been a lot of focus on production, that is to say inhibiting beta secretase and gamma secretase, and increasing clearance. That's the immunotherapies, that's the vaccinations, and the monoclonals. Why do I put it this way? Because the production-based approaches, the secretase inhibitors, for the most part, have not yielded a lot of results and therefore are kind of falling out of favor in the present time. But monoclonal antibodies have gone through multiple generations, multiple iterations, and we're now finally seeing some progress that's worth considering. So that means that clearance seems to be continuing on despite the fact that production has not proven to be successful. So the first gen of clearance-based monoclonal antibodies included bapineuzumab and solanezumab. And these monoclonal antibodies moved all the way through phase 3 trials and showed no significant benefit in altering the rate of progression. The one thing you need to know about bapineuzumab is it was every quarter, and there was no difference between treatment and placebo in ApoE4 carriers or non-carriers. However, the dose in the phase 3 program was 1/10 what was used in the phase 1 program, mainly because of safety concerns. So the question has always been with bapineuzumab, did we just underdose the drug? Solanezumab had a very excellent safety profile and was used in mild moderate. There have been now 3 studies, and the latest study read out at the end of 2017 showed that it did not reach its pre-specified primary endpoint. But again, safety profile was very good. And so in symptomatic Alzheimer's dementia, the clinical development program has been halted. It is still being used in the prevention trial known as A4. The BACE inhibitor, verubicigostat, has been used in 2 clinical trials. The prodromal study has been halted. It is continuing on in some of the dementia studies. If you look at that at face value, you say monoclonal antibodies are dead. The amyloid hypothesis is dead. We need to move on. And I'm happy to say there are still people who are going to persist, and I'm very, very encouraged by that. And there are multiple new monoclonal antibodies that are worth this audience considering. One is gantenerumab. And gantenerumab is a subcutaneous drug, and although it did not meet its pre-specified endpoint subcutaneously at 2 doses, 105 milligrams or 225 milligrams, subcutaneously once every 4 weeks, it did show that it's slightly altered the people likely to get a clinical benefit, and it did reduce amyloid in the brain. There is now a new phase 3 study going on at much higher doses, and there is suggestion that it can alter biomarkers as well. Crenezumab is another monoclonal antibody, and crenezumab actually showed that the pre-specified primary endpoint did not meet its outcome. However, in the sub-analysis of the mildest group, it showed a benefit, particularly in the mini-mental 22 to 26 range, and it has now gone back into phase 3 studies with a very narrow mini-mental range. It is also being used in the autosomal dominant Alzheimer's group in Colombia, South America, as part of the Alzheimer's Prevention Initiative. So crenezumab is moving forward through the phase 3 program. A third monoclonal that's worthy of consideration is aducanumab. This is a monoclonal antibody that is a humanized monoclonal. Basically, what the company did is they took natural antibodies out of elderly patients and found that when they enriched them, that they could create a monoclonal antibody that has some targeted beneficial effect. Why is everybody excited about this? Because it's the first time we see what's called directional concordance. That is to say that the clinical direction and the amyloid reduction direction went in the same direction. This slide shows in a dose-dependent manner from placebo to 10 milligrams per kilogram, given every 4 weeks, that the drug had increasing amounts of reduction in the amount of amyloid in the brain. And this was very, very exciting. The other part of this that's very exciting is that in addition to showing a dose-dependent reduction in the amount of amyloid in the brain from placebo to 10 milligrams per kilogram, we showed a dose-dependent directional improvement or lessening of the rate of decline in the mini-mental and the CDR sum of the boxes. The higher the dose, the less worsening, less progression on the CDR sum of the boxes, and same in the mini-mental state exam range. So my point is that there's clear evidence that reduction of amyloid was associated with a potential clinical benefit. And that's what got people excited about the amyloid hypothesis again, and that's what got people excited about the idea of passive immunization or passive immunotherapy to remove amyloid. However, before we get really excited and say we have a cure or the definitive treatment, you need to know there are some side effects and risks related to aducanumab that are being managed right now, and we'll learn more about that as the time goes on. Aducanumab has now been moved into long-term clinical trials. There is now data out to 2 years showing that there is sustained benefit over time and that the incidence of ARIA, which is a side effect risk profile, does not increase over time. So what was seen initially does not continue to be seen as we move into the open label extensions. Specifically, there are no new cases of ARIA that we have to worry about or manage. So we know that the initial benefit continues and that it is persistent up to 2 years, and the amyloid reduction effect continues up to 2 years, and there's no increased safety signal risk. We know that the aducanumab has now moved into a very large phase 3 program called the EMERGE study with 1,350 people. It is mild cognitive impairment with a CDR of 0.5, that's the global scale, amyloid PET, mini-mental 24 to 30. They're randomized to 3 arms, placebo, low-dose aducanumab, high-dose aducanumab, dosing once every 4 weeks, IV for 18 months, with an outcome of a CDR sum of the boxes. A second study is the ENGAGE study, which is a little bit farther along, and that is up to 24 months, 1-to-1, based on their APOE status. So that's 3 drugs that we're excited about, right? So that's gantenerumab, crenezumab, aducanumab. Let's talk about the 4th monoclonal antibody, passive immunization, again targeting amyloid, and that's BAN2401. In this case, the phase 2 study was done, a huge study, 856 patients. There were multiple arms, 2.5 milligrams every 2 weeks, 5 milligrams every month, 5 milligrams every 2 weeks, 10 milligrams every month per kilogram, 10 milligrams per kilogram every 2 weeks, or a placebo. So multiple doses plus placebo, so 6-arm study. They used a randomized Bayesian design to automatically allocate new patients into the treatment arms, showing a higher probability of efficacy based on interim analyses. And they looked at up to 18 months, including biomarkers, with an outcome measure different from what we've seen before, something called the ADCOMS. The ADCOMS is kind of a hybrid composite of ADAS and CDR sum of the boxes, which are clinical trial instruments that we do not see in clinical practice, but can be derived to show a clinical benefit. One of the things we're very excited about when it comes to BAN2401 is it showed like aducanumab, in a dose-dependent manner, a reduction of amyloid. So the higher the dose, the more amyloid cleared. And this was statistically significant at every single dose. At the highest dose, the amazing part about this is that 81% of patients converted to amyloid negative, as if they did not have Alzheimer's pathology in their brain, at least amyloid pathology in their brain. With that, we saw slowing on the rate of decline on ADCOMS. And in fact, when you looked at it, the clinical decline in the highest dose, that's 10 milligrams per kilogram every 2 weeks, showed a 30% reduction in the rate of decline compared to placebo, and that the effects were seen as early as 6 and 12 months. So we are now starting to think that in a dose-dependent way, we can see higher doses associated with slowing of cognitive decline, and that it can be seen at 18 months with a CDR sum of the boxes up to 26%. There are some issues about safety that we need to think about, and that includes the ARIA like we saw in aducanumab. But the general safety profile can be managed well. We know that it does have positive effects on CSF outcome measures, biomarkers in particular, and that the adverse event rates do not increase depending on which treatment arm you're in. So the placebo group incident rate of adverse events is 26%, but the 10 milligram per kilogram monthly treatment versus 10 milligram per kilogram biweekly treatment have roughly the same amount of adverse events. So we know it's not just a dose-dependent issue, and that the incidence of ARIA kind of caps out at around 10 to 15%. 4 monoclonals we're very excited about. That's gantenerumab, crenezumab, aducanumab, and BAN2401. My point is that there's new life, new energy, new interest in the idea that clearing amyloid may have a benefit effect, and we're starting to finally see directional concordance that the lower the amyloid, the more stabilization or the lower rate of decline in the treated groups. So we think that there's some hope for future around the monoclonals of passive immunization, particularly the ones I talked about. We also said that there is evidence that the amyloid producers, the beta secretase inhibitors, have not shown as much effect. But people are not giving up on that approach. And two things that are relevant to this discussion are there are still some BACE inhibitors that are coming along. There are different monoclonals that are targeting different things being developed. And now, for the first time in probably 12 to 15 years, we're starting to see active vaccination coming back into the clinic. This is very exciting, the idea that you could immunize a patient against amyloid, and the idea is that in so doing, you could prevent future production of amyloid. It was originally proposed about 15 years ago. First round of treatments were not very encouraging because there were some side effects and risk tolerability issues, but second generation vaccines are now coming back into practice. People are going to ask then, okay, you talked about amyloid, what about tau? And tau is a therapeutic target. Tau makes a lot of sense because, as I mentioned before, tangles and tau correlate with clinical progression. And we know that the spread of disease follows the tau progression from the hippocampus to the entorhinal cortex to the temporal lobe throughout the neocortex. So we know that the spread of tangles and tau correlates best to clinical progression. The reason people haven't rushed to create tau-based approaches is because tangles and tau are intraneuronal processes and therefore have been hard to get to. But we are now starting to see the emergence of multiple tau-targeted therapies. One of the ideas that's really taken off in this space is the idea that, as I mentioned earlier, when neurons degenerate, the little forms of phosphorylated tau spread from from neuron to neuron in a prion-like approach. And in so doing, you could say, well, we'll find a monoclonal antibody that grabs those to prevent the spread of that prion-like spread from neuron to neuron. And there are now multiple clinical trials in phase 1 and phase 2 testing different monoclonal antibodies targeting that spread. There have been a few drugs that are called kinase inhibitors. We're trying to prevent the hyperphosphorylation of tau. Those have had variable results. So let's kind of wrap up and talk about Michael for a few minutes. After discussion with his neurologist and his wife, they were both kind of feeling overwhelmed with the volume of information. A 2-week follow-up visit was scheduled and a decision to make about treatment. I say to you that I have 3 difficult conversations when I'm talking to my patient. One is the diagnosis. So I feel what Michael and his wife are dealing with. I'm that neurologist that tells people what they're dealing with. That's always one of the most difficult decisions, what to expect, what's the prognosis, what does the future look like. Oftentimes I'll bring in a social worker to start talking about these things. We talk about difficult things like driving, and we talk about that as a placeholder for future discussions. And then we talk about what management, what expectations there are. So I think this is appropriate to give them some time to digest the information. I know that I always joke that they're going to go home and read Dr. Google, and I'm okay with that because we're going to talk about what did they learn, what they need to know. So I expect the physicians to be informed about what the people are reading about. And then that's a good time after that second follow-up visit to really talk about what are the expectations and whether clinical research is appropriate after you decide on treatment. And I think that it's appropriate to put the patient on symptomatic treatment. In this case, donepezil was picked. He's tolerating it well. He continues to undergo regular assessment for cognitive decline. People ask me, should we do serial testing as part of clinical practice? The answer is no. I don't CSF test repeatedly. I don't PET people repeatedly. So the conclusions here are that Michael's story highlights several key issues in diagnosis and treatment of Alzheimer's disease. 1, challenges related to early recognition of Alzheimer's disease. Understanding that mild cognitive impairment is a time for evaluation and intervention. 2 is transforming its evaluation from a diagnosis of exclusion to a diagnosis of inclusion, and specifically using biomarkers to inform the clinical decision-making process. 3 is to recognize that even though there are limited effects of the approved treatments, it doesn't mean you shouldn't treat, it doesn't mean you shouldn't use the treatments, it just uses it as a symptomatic treatment as a starting point as part of the treatment, and that you should think about Alzheimer's disease and Alzheimer's dementia as a treatable condition. Key learnings from clinical trials of investigational therapies have failed to meet their primary endpoint, have still informed the field to the point where we're now moving toward drugs that may have benefits in the near future to address the disease process. And with that, I thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/JJS. This activity is supported by an educational grant from Biogen. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.